Bismillahirrahmanirrahim. In the name of Allah, the most beneficent and the most merciful. Assalamu alaikum, everyone. I hope you all are well. This is Dr. Mariam Hena, G1 Meta Campus Coordinator. Thank you for connecting today in G1's second session under Meta Campus and in collaboration with CYPRO. Our topic for today's discussion is the management of low-risk prostate cancer with its options and recommendations. The experts for today's talk include Dr. Nadeem Parvez, our Honorary Teacher and Vice President Mestro, Dr. Rabna Vaz, Consultant Oncologist and Head of Oncology Department at Enmol. This session will be facilitated by Dr. Amin Zia, Postgraduate Resident at Enmol, under guidance of Dr. Sadia Sadek, who's Senior Medical Officer and Consultant Oncologist at Enmol. So without further delay, let us start the session. Over to Dr. Amin.
हेलो अस्सलाम वालेकुम टू एवरीवन आवाज आ रही है मेरी
Yes, Dr. Amin, we can hear you. Start.
अच्छा Bismillahirrahmanirrahim. Today we are going to discuss the management of low risk prostate cancer. Management is a broad term which includes the prevention, the screening and early diagnosis, early intervention and follow-up. So it is not only the treatment, but also the prevention, the screening, and the early diagnosis are part of the management. So inshallah, within 40 minutes, we will be able to discuss all these topics. So the layout of our presentation will be the clinical presentation, the diagnostic methods, the primary treatment options, the pros and cons of every treatment option, and at last, we will see the lifestyle modification and role of genetics in the prostate cancer. अनम्यूट सारे हो गए कहीं से शोर आ रहा है थोड़ा सा
Please everyone mute yourself. Please carry on, Dr. Amin.
Yes. Acha. So the introduction to prostate cancer. Prostate cancer is most common non-cutaneous malignancy in the US, second most common cause of death. And the median age of diagnosis is 60 years, and the age-specific survival is 95% for all stages of prostate cancer. This data is for, but in Pakistan, it is the sixth most common cancer. And the reason is, as we don't have a screening program. And the other thing is that apart from being a cancer with a specific survival of more than 95% and being the second leading cause of death, the reason behind is the high incidence of prostate cancer in that part of the world that is due to high screening rates. So if we see the anatomy of the prostate, it is a small gland which is present in the male genitourinary tract, and it is between the bladder and rectum. Bladder का जो base होता है वहां से लेके in front of the rectum, this gland is present, and usually before the age of 40 years, it is a small gland with 25 gram of weight and 20 cc of volume and 3 into 5 centimeter size. But once a man crosses the age of 40 years, suddenly starts increasing size of the gland, and it also starts producing an enzyme which is called PSA. जो PSA produce होता है, that starts with an increasing rate after 40 years, और 50 year में जाके इसका जो rate होता है वो और ज्यादा हो जाता है, और 8 years of age it starts producing 2 nanogram per ml per year of PSA. This PSA, some part of this PSA gets into blood by some unknown mechanism. The remaining part, the majority of this PSA is in the fluid. So when we will go to the screening, we will discuss in detail about the PSA. But right now in this slide, if we will see that this gland is just below the bladder and just in front of the rectum, this is important to remember that when we are going to radiate this gland, these two structures are going to affect and are going to to complicate our plan of radiation. This slide is also important. If we see microscopically, it has three important zones which are remembered by P, C, and T. The P is the peripheral zone, the C is the central zone, and the T is the transitional zone. These three zones are the glandular part, which contains the actual prostate gland. So if you see here that these three parts are a bit away from the urethra, so any pathology in these parts will not cause the obstructive symptoms so much. But if you see the transitional zone, it is the one which is encompassing the urethra. So any pathology in the transitional zone will cause more obstructive symptoms than any pathology in the peripheral and the central zone. Unluckily, 70% of the cancer is there in the peripheral zone and 10 to 15% of the cancer is there in the central zone. So the prostate cancer, when it is limited to the prostate, it is asymptomatic usually. It does not present with the obstructive symptoms. The benign prostate hyperplasia, which is 100% in the transitional zone, will present with the obstructive symptoms. The good part, the good news is that the peripheral zone and central zone are in the posterior part of the gland, so they are accessible for the digital rectal examination. So DRE has some role there. If you find some nodularity, some hardness, and some asymmetry in this part, it will lead us to the diagnosis of the cancer. So this is important. Once again, the P, C, and T, the P is the peripheral zone and C is the central zone where 95% of the cancer is found, and it is accessible for the digital rectal examination. And now, as for making the presentation a bit interesting, I'm going to ask about. This is a question from the Devita, and it says that a 51 years old man with a strong family history of prostate cancer, normal digital rectal examination, no significant comorbids, and PSA of 2.9. Seeks advice on prostate cancer prevention. He is sexually active in a normal relation and denies any urinary or rectal symptoms, which is the most likely to reduce his risk of developing prostate cancer. So there are four options: reduce the alcohol, start taking vitamin E, avoid high fat diet, and increasing calcium and vitamin D. So all of us will think an answer, and we will go to the next slide, that why prostate cancer is there and how we can prevent it. That are the risk factors. So the strongest risk factor is the age. About the age, I would say that there was a trial that 30% of the postmortem reports between 50 and 60 years and 70% of the patient above 70 years had prostate cancer on their postmortem reports. And another trial says that 80% of the people, when they are in their 80s, they have prostate cancer. So how big is this age factor? Is that after below 40 years, we don't have prostate cancer, but 80% of the people at 8 years have prostate cancer. The second one is the African American race. They don't only have the prostate cancer, but their prostate cancer is aggressive too, with high PSA, high Gleason score, and more advanced stage of diagnosis. The family history is very important, twofold with 1 degree relative, 1 first-degree relative, fourfold with 2 relatives, and 11-fold with 3 first-degree relatives. So if someone have prostate cancer in the family, even though in our country we don't have a screening program, but we must encourage them to do the PSA after 40 years of age. The other one is the dietary factor. The only factor which has been proved by study is the high fat diet, which increases the prostate cancer. And the BRCA2 mutation, remember that it increases the prostate cancer by 5 folds of the normal population. So if you go, yes, ma'am.
Dr. Mean, I would like to ask Dr. Nadeem, sir, how frequently do you see BRCA mutation in your patients? As you are working in a setup where screening has been is being done, so how often do you see a BRCA2 mutation patient positive of prostate cancer, and what are the necessary measures or the preventive measures which can be opted in those patients?
Thank you very much. Assalamu alaikum, everyone. Thank you for this effort. So it's a good presentation. The BRCA test we don't do upfront to any patient. This is only reserved for the patient who are either metastatic at presentation or advanced stages, because the management does not change by BRCA except for the setup where the disease are metastatic and there are different treatment options. So for a screening stage, we don't do that. For a metastatic stage, the percentage is smaller. I would say this is an estimate, about 10% or less, and not very common for BRCA to be positive.
Thank you, sir.
Thank you so much. Madam, to add to this one, the BRCA mutation, how it can help the patient and how can it help the family members. So for family members, if someone have BRCA2 mutation positive, then we can screen the whole family for breast ovarian syndrome for the female patients and the other cancers in the male patient. And for the patient, if the BRCA2 mutation is positive, the prostate cancer is going to be to be high risk prostate cancer. So we can't opt for active surveillance or observation in those cases. So going back to our question, so certainly the answer is avoiding high fat intake and reduce the BMI and increase the physical activity is the answer, because alcohol intake, smoking, taking vitamin E, all these had been widely studied in the literature but has not been proven. So going to the genetics of the prostate cancer, 11% of the prostate cancer patients have some germline mutations, and two of the germline mutations which are very important are BRCA2 mutation and the Lynch syndrome, which are the DNA mismatch repair genes are mutated. So any patient presenting, as sir has told us, that we are not doing for all the patients, but for exam purpose, these two are important. And the BRCA1 and 2 mutation are important for the patient because these mutations will make the prostate cancer more aggressive, and the Lynch syndrome is not associated. But when the prostate cancer has a failure to the first, second, and third line drugs, then we can add pembrolizumab to the patient which have MSI high. So they can be for the metastatic prostate cancer. And the somatic mutations are there in 89% of the patient, and there are certain mutations which are actionable mutations against which we have drugs. So if the patient is affording, we can advise an NGS or a mutation profile for the metastatic prostate cancer. About the sign and symptoms for the low risk prostate cancer, as we are going to discuss today, most of the patients are going to present asymptomatically. So 47% of the patients will have no symptoms, as we have discussed that until and unless the cancer is limited to the prostate, it will not cause symptoms. The others are the urinary frequency, urinary urgency, urine stream and hematuria, hematospermia, bone pains, and lower leak edema when there are nodes. So all these are the signs and symptoms with which the patient can present. And now we will.
I have to ask Dr. Mekan, sir, how often do you see low risk prostate cancer patients, and do they have any symptom, or what are the clinical presentation in your clinical setting? Sir, Dr. Mekan.
Okay.
Okay,
Dr.
Dr.
Sadia,
Amin, please carry on.
signals were weak and I was unable to get your question. I think you asked what is the most common symptom at presentation for CA prostate. The population that is coming to our clinics.
Yes, sir. Yes, sir. How?
I think, Dr. Amin, you should continue.
Yes,
I'll
sir.
come later.
Okay, sir. Okay, sir. Let's start with a scenario which I have made. And 53-year-old apparently health male came for a routine checkup. He has no active complaints. He has no family history of malignancy. He is worried as one of his friends has been recently diagnosed with prostate cancer. If you are sitting in our clinic and a Pakistani man with 53 years come to us, what will be our plan? So will we advise serum PSA, a multiparametric MRI of prostate? We will reassure the patient and send him home. We will advise finasteride for 7 years. Can we advise vitamin E and selenium? Can we advise ultrasound, prostate, digital rectal examination, or a trust biopsy? So this is a question I have made. If anyone want to have any comment on this question, is welcome. Otherwise, we will continue the slides. So this was a scenario which was I supposed to make it to make the idea about the prostate cancer screening more clear. So for an American or a European person, if he presents at 53 years, he will certainly undergo for the PSA screening, because according to the NCCN guidelines, for an average risk person at the age of 50, screening starts. For a person who is American descendant or has one first degree relative who has been diagnosed with prostate cancer, he will start at 45 years. And for a person who has 2 or 3 first degree relatives, the screening will start at 40 years. So look how important is the family history in the screening part. And the other slide is showing that what will be our action after we advise a PSA. If the PSA is less than 1 nanogram, we will advise the PSA at 2 to 4 years interval. If it is between 1 to 3 every 1 to 2 years, and if it is greater than 3 nanogram per ml and or we have a suspicious DRE examination, then we will usually go for biopsy. So the screening is one of the very debatable topics in the prostate cancer. Even in US and European trials, they advise the screening, and in other way they disguise the screening. There are two terms which are actually confusing. That is the our diagnosis of prostate cancer. What does the term our diagnosis mean? Our diagnosis is to diagnose a cancer which, if not diagnosed, will not affect the morbidity and mortality. So as I have told you earlier, that 70% of the biopsy reports above 70 years of age had prostate cancer, and 80% of the people at their 80s have prostate cancer. So this is some silent disease which is going on, and if we will not diagnose it on time, it will not affect the life and the age of the patient. So if we go for screening, if our diagnosis the cancer, and many trials have proven that the screening does not affect the mortality of the prostate cancer. So it is a debatable topic anyway. The NCCN recommends the screening at 50 years of age, and in our country, we don't have a screening program. So according to the NCCN guidelines, this gentleman, we will advise serum PSA level. So the other options about the selenium and vitamin A, there was a trial which was called the SELECT trial. And finally, the SELECT trial reached the conclusion that there was no benefit of giving vitamin E and selenium to a patient to prevent the prostate cancer. And their recent data in the ESCOSEP 2020 said that giving vitamin E without selenium even increases the risk of prostate cancer. So this option was wrong. There was trials about finasteride and butasteride, which are 5-alpha reductase inhibitors. These are very exclusive trials. They have given the finasteride for 7 years and equally the dutasteride, and the final result showed that they increase the possibility of prostate cancer because they delay the diagnosis. As we know that they decrease the PSA level, they decrease the sensitivity of the PSA, and they decrease the possibility of diagnosis. So this option is also wrong because we cannot give finasteride and dutasteride to prevent the prostate cancer. Now the same person, the same patient, we did a digital rectal examination which was unremarkable, and we advised serum PSA level, and the PSA level came out to be 5 nanogram per ml, which is more
Dr.
than
Nadeem,
yes, ma'am.
we would like to know Dr. Nadeem's experience about screening.
Okay, madam.
Okay, thank you very much. I just want to give you some little bit of information about that. So in the past, when cancer is called as a disease of the old age, And when in the Western countries, most of the patient have their GPs or general practitioners, so they go for yearly checkups. And in that yearly checkup, they already have their PSA checked. So this is out of a screening. I would say is a random screening, not a programmed screening program or active surveillance. So in this way, most of the patient in the Western countries from age of 60, they do have yearly PSA, even if they're asymptomatic. So I just tell you a little bit about the symptom that the PSA cancer, prostate cancer is not a symptomatic disease, is asymptomatic. And the symptoms which comes to prostate cancer is the it's actually very late stages when the disease is mostly in the peripheral zone, unless the disease is in the central zone where they compress the urethra, and that is also late when the patient have symptoms. So basically, symptoms are for other reasons, for BPH or for other reason, but that can make us to lead towards diagnosis, a guide towards diagnosis. But we don't expect that prostate cancer in early stages is going to be symptomatic. So therefore, it is we screen with the PSA, and we screen with DRE, because also PSA is also not 100% to diagnose or guide us. So we have to combine both, because sometimes there are nodules and the PSA is normal, and then we diagnose because of the nodule. So there are two reasons to diagnose. So random screening is common in the Western country. When they did the randomized trials, and they said one trial was positive, that it does improve survival, the other was not, negative. So the reason was that because already those patients have yearly PSA check. So we are talking about an active surveillance program, which is on top of random screening. So in our country, it's very different. So if you ask me, I will follow that what you presented, that what age to 40 or 50. The other difference I notice in the East and West, that the age, actually the age is longer for the people, and disease come more in the later stage. In our countries, the life expectancy is not as long. And I also found that about a 10-year earlier, I would do any screening program. So if I need to do, for example, breast or prostate. So in this scenario, this what you propose for the screening, even though it's not followed in our countries, but this is the best to follow, like 40 for very high risk, 45 for medium risk, and the other ones from 50 onward. So this is the story for the screening. In our country, it is very different. Anyone you get above 50, do PSA test, because they're not doing random PSA screening. And for this reason, most of the time we got patients are late diagnosed, because they don't have random PSA screening of yearly checkup of the PSA at age 60 or more. So I would say that we should not shy off from the screening. And we will talk later about a little bit more about intervention, whether benefit, mortality, morbidity. We will talk about that as we go along.
Thanks a lot, sir.
Thank you, sir. So the message is that whenever we catch a patient above 50 years, we must advise a PSA level, because it's not a costly test and it can save the lives. So in our patient and our supposed patient, the PSA level is 5 nanogram per ml. So what next is the repeat the PSA, free PSA ratio, PSA velocity, PSA doubling time, PSA density, trust biopsy, and MRI. I put these options there just to elaborate these terms, which are important as a student for us. Apart from that, there is a question from the Devita, that is a bit from the biostates, that the PSA threshold for, if we put the PSA threshold 4 nanogram per ml, the sensitivity is just 24%. Look, that is very less sensitive when the PSA threshold is 4 nanogram per ml. Now the question is that if we put the PSA threshold 2.5 nanogram per ml, what will happen? Will the positive predictive value decrease or increase, or the sensitivity will decrease or increase? So the positive predictive value is the term which I am going to elaborate in the next slides, and we will come back to this question. So PSA, as I have told you earlier, that it is an enzyme which is used for prostate cancer screening. It also tells us about the tumor burden. So the low risk, intermediate risk, high risk depends upon how much PSA is there in our blood. It is the most predictive factor for the biochemical recurrence. Once the patient has been treated, if the PSA comes back, then it is the most predictive factor for recurrence. The 5-alpha reductase inhibitor, as I've told you earlier, that it decreases the PSA level. So if the patient is taking it for 6 months, you have to multiply the PSA by 2 to get the corrected PSA. And if he is taking for longer time, you have to multiply 2.3 to get the corrected one. The age is very important. Age divided by 10 minus 1 is the age specific range. We have to, 4 nanogram per ml is for 50 years. So divide 50 divided by 10 is 5 minus 1 is 4. So, but a patient comes at 80 years, then it will be 7, will be the upper limit. Its specificity increases with the age. Its half-life is 3 days. So, if a patient had undergone radical prostatectomy or TURP or any instrumentation or has bacterial prostatitis or any other cause which can increase the PSA transiently, we have to wait for 4 to 5 half-lives to repeat the PSA to get, because it is a test which is increased by these minor things. तो हमने 3 से 4 हाफ लाइव्स का वेट करना है, फिर हमने पीएसए को रिपीट करवा देना है. तो द पॉजिटिव प्रेडिक्टिव वैल्यू, जो ये क्या होता है इसको हम इस स्लाइड में डिस्कस करेंगे. दैट यूजुअली द पीएसए इज लो सेंसिटिव एंड लो स्पेसिफिक इन एसिम्प्टोमेटिक पेशेंट्स, and positive predictive value is 10%, 25%, and 64%. For the PS serum value of 4 nanogram, 4 to 10, and 10 nanogram per ml. अगर हम किसी पेशेंट का 10 नैनोग्राम पर ml PSA है, उसकी अगर हम बायोप्सी कर लेते हैं तो बायोप्सी का पॉजिटिव आने का चांस 64% है. लेकिन अगर हम किसी का 3 पे कर देते हैं या 2 पे कर देते हैं तो वो फिर 8 या 10% हो जाएगा. Its positive predictive value is increased when the race in PSA is also supported by findings of DRE, multiparametric MRI of prostate, high PSA velocity, high PSA density, and low PSA ratios. So ये जो low free PSA ratios, so these tests are there to support the PSA whether we are going to do a biopsy or not. So if we go back to the question, अगर हम जो PSA का थ्रेशोल्ड है उसको 2.5 नैनोग्राम पर ml पे लेके आ जाएंगे तो इसकी सेंसिटिविटी बढ़ जाएगी. यानी कि अगर हम एक पे भी बायोप्सी करना शुरू कर देंगे तो PSA की सेंसिटिविटी बढ़ जाएगी, बट इट विल डिक्रीज द पॉजिटिव प्रेडिक्टिव वैल्यू ऑफ द PSA. तो इसका जो आंसर है वो ए है. अच्छा, free PSA क्या होता है? Free PSA is the unbound part of the PSA. The lower is the free PSA, the higher chance is of prostate cancer. So first we advise a PSA, then we advise a free PSA, और इन दोनों को डिवाइड कर देते हैं. अगर इसका रेशियो लेस देन 0.2 है तो कैंसर का चांस ज्यादा है. वी कैन कंबाइन इट विद द PSA वैल्यू टू इंक्रीज आवर पॉजिटिव प्रेडिक्टिव वैल्यू. द नेक्स्ट थिंग इज द PSA डेंसिटी. वो हम PSA अल्ट्रासाउंड करवा लेते हैं प्रोस्टेट का और वॉल्यूम के साथ देख लेते हैं. इफ इट इज 0.1 नैनोग्राम पर ml पर cc, इट इज द नॉर्मल थिंग. मोर देन दैट विल इंक्रीज द सस्पिशन ऑफ कैंसर. और PSA डेंसिटी का प्रोग्नोस्टिक वैल्यू भी है. आगे जाकर हम देख लेंगे कि वेरी लो रिस्क और लो रिस्क प्रोस्टेट कैंसर में जो डिफरेंस है वो PSA डेंसिटी का है. If the density is less than 0.15 nanogram per ml per gram, that is called the very low risk prostate cancer. The PSA velocity has both prognostic and diagnostic value. If the PSA velocity is more than 0.75 per nanogram per ml per year, it is suggestive of prostate cancer. It is inversely proportional to the PSA doubling time. The more is the velocity, the less is the doubling time. और doubling time का जो upper limit है वो less than 6 months है. अगर 6 months से पहले PSA double हो जाता है तो it shows the recurrence or failure of the disease after EBRT or the radical prostatectomy. Now हमने अपने PSA values के साथ और चीजों को भी ऐड कर दिया, and we came up with the conclusion that we are going to do a trust guided biopsy of our patient.
Sir, I would also like to ask Dr. Nadeem, sir, if you find a patient with a PSA of value 5, then what would you recommend? Do you repeat a test, and after how many days or weeks, and then if it's again raised, then what is the next step would you opt?
So I would, many cases between above 4 PSA, the positivity rate is not very high, like it'll be 40% about roughly between 4 to 11. I'm not saying only 4, but between 4 to 11, the biopsy positivity rate in one of the study I read of was 40%, which is, I think, in my opinion, high enough. So, but now we have a new tool, which is a good tool, non-invasive tool. So I would, after is above 4 PSA, I would not let it go only to come back, because sometimes it also not very common when prostatitis or infection, other reasons can raise PSA above this value. So some people, they give antibiotic for a month and bring back. But I would say we have a better tool available now if patient can afford to MP MRI. So I would do above 4 PSA, I would do MP MRI and take the decision from there. So that would be for the diagnostic tool, because this together, PSA and the MP-MRI together, it actually increase our knowledge whether we should go for biopsy or not. And for that, actually, there are multiple studies going on, and they are not going to be like current standard practice. So it's but it's being used. So if PSA above 4, I do MP-MRI, and MP-MRI if there are lesions which are Pirates 2 or under, they are not sensitive. So when the MRI shows us lesion Pirates 3 or above, especially 4 or 5, then I will definitely go for biopsy. Even 3, I will go for biopsy for those patients. And we are talking about the systematic biopsy, means 12 course versus only the lesion area to biopsy. So there are more tools now available that I would not just ignore PSA 4 and don't do anything. I would do MRI scan and take it to further step before do biopsy.
Thanks a lot, sir.
Thank you so much, sir. So our touch-guided biopsy, we take 6 to 12 cores. Half of the cores are taken from one lobe and half from the another lobe. And if we are doing the biopsy by MRI, through MRI, less cores can be enough for the diagnosis. And the biopsy comes out to be a senior adenocarcinoma 95%. And luckily, this is the histology with the best prognosis, and all other histologies are 5%, which can be ductile, the transitional cell, mucinous, and small cell and lymphomas. All of these are poor prognostic than the adenocarcinomas. There are no good histologies in prostate as in breast. In the 12-core biopsy, they will tell us about the Gleason score. There are two things. One is the Gleason grade, and the other is the Gleason score. The Gleason grade is 1 to 5, which is well differentiated, to very poorly differentiated. And the primary Gleason pattern is the pattern which is more than 50% of the total pattern, and the secondary pattern is between 5 to 50%, and they add up the primary Gleason pattern and the secondary Gleason pattern to give us a Gleason score. For example, it is a 3 plus 3, it means that moderately differentiated cancer is there in the more than 50%, and between 5 to 50%, both are in this range. So based on this Gleason grading and Gleason score, we get a score. The other thing is the CT scan, which is the contrast enhanced CT scan of chest, abdomen, pelvis, which we are doing to see the disease in the pelvis or in the liver or in the nodal disease, especially. So the CT scan has the limitation of seeing the disease within the prostate gland. It will see the extra capsular extension, but the soft tissue parts are not better seen with the CT scan. So better is a multiparametric MRI. A multiparametric MRI is an MRI with the T1, T2 weighted images, plus it includes the diffusion weighted images or the dynamic contrast enhanced images. It is called a multiparametric MRI. It better stratifies the patient, and it is the MRI which detects the extracapsular extension. The T staging is best done with this MRI, and it is equivalent to CT scan for pelvic lymph node evaluation. As we are discussing the low risk prostate cancer, cancer which is limited to the prostate, so the multiparametric MRI should be part of the diagnostic work of low risk prostate cancer. The other is the PSMA or gallium-68, F18 or gallium-68 PSMA, PET-CT or PET-MRI. It is a diagnostic tool which can be used for initial staging if we want to skip the MRI and CT scan. But usually it is reserved for the recurrent disease, for the metastatic disease, and the disease once progresses, we go for the PSMA scan. The bone scan is indicated when the PSA is more than 20 or the Gleason score is more than 8, or if there is a T3 to T4 disease. So usually in the very low risk, and forever intermediate risk, a bone scan is not indicated. So after the workup, we do a staging. We all are aware of the staging that the T1 is limited to the prostate, but the disease is not palpable. T2 is limited to the prostate and disease is palpable. T3 is
Dr.
extracapsular.
Mean,
Yeah, madam.
I would like to ask Dr. Nadeem, sir, if you find an elevated PSA and multiparametric MRI has shown one abnormality in one lobe, then what are the other investigations which you usually offer or which are recommended?
At this stage, we need to make the diagnosis because I was talking about I would combine the result of PSA and MP-MRI for the reason that it will make the chances of us to diagnose the high grade or higher stage patient earlier. But if patient is if it is less than 2 pyrids and even PSA is a little bit higher, so there may be cancer. It's not that there may be no cancer, but the chances of cancer to be higher grade will be high pyrids as well. So I would reserve my biopsy or invasive procedure for the patient who are more on the risk, and they can be negative as well. So there are lots of improvement in the field. So PSA was one factor, MP-MRI added to another. And I would, at this stage, if I'm suspicious, I will go for biopsy and no other workup. A CT scan is barely not used. PSMA PET scan is reserved for more higher stage because availability limited. Also, cost is there. So I do the PSMA PET scan. I would reserve it for other patient, not for this type of patient. So next step for me is a biopsy, and there is improvement in biopsy as well. So there was transrectal biopsy was carrying the risk of septicemia in some patient, and in some cases it would be life threatening. So what would I would do a transperineal biopsy for this patient. And the way we do it actually in my center also, I'm doing transperineal biopsy. And I'm involved, actually, I'm doing myself, not based on urologist, but urologist is part of team with us to learn this procedure. So when we do transperineal biopsy, is the risk of infection is low, and we can target the lesion. We have option of MRI fusion with ultrasound image, where we can target the pyrid lesion. So the new question about the biopsy in these type of patient is whether we do all systematic biopsy, like all area to biopsy and the dominant lesion, or just to do the dominant lesion biopsy, because this is still in the screening stage. And if we miss some time, some cases, they may be a higher chance, they may be lower grade, and they may have time to, when we see progress in PSA, or if we see the changes in MP-MRI in future on a yearly basis or later, then we can do biopsy, we can repeat biopsy. So we may miss, but the chances we may not miss the high grade tumor. So we can, so that the question now is PSA, MP-MRI, and biopsy the systematic plus dominant lesion, or only dominant lesion, which may be a couple of needle or 3-4 needle. So that's the question. But my next step will be, after suspicion, I build with PSA and MP-MRI. I will go for transperineal biopsy if available. Otherwise, transrectal biopsy.
Thanks a lot, sir. Yes, Dr. Mean, please carry on.
Thank you, sir. So in this slide, the importance is the T2A. So before the T2A, it is low risk prostate cancer, cancer which is involving less than or half of one lobe. T2B and T2C are the things to remember, because it makes the cancer in the intermediate risk, and after T3 and T4 it is the high risk. So B, C are the important, T2B and T2C. The other important thing is that mets in the regional lymph node. The regional lymph nodes are internal iliac, external iliac, obturator, and presacral lymph nodes are the regional lymph nodes, which makes the N1 disease. And the non-regional lymph nodes make it M1A. So if we look at the others, the next slide, the regional lymph nodes make the stage 4A and the non-regional lymph nodes and R other mets makes the stage 4B. So the difference in the management of stage 4A and stage 4B is that the stage 4A is taken with curative intent, but stage 4B is taken with palliative intent because it is the disease is outside the regional nodes. Now, after evaluating the results of the PSA and other investigations, the primary oncologist advised stress-guided biopsy report of the same shows a senior adenocarcinoma, Gleason score 3+3, 2 by 12 cores are positive. His PSA density is 2 nanogram per ml per cc. Multiparametric MRI shows disease limited to less than half of the left lobe of prostate gland. CT, chest and abdomen are negative for any nodal or metastatic disease. So define the risk group in which this patient fits in. How will we decide the life expectancy of our patient? Is a bone scan indicated in this patient? What treatment options are possible for this patient if his life expectancy is 12 years? So the first question is very important. How we will risk stratify this patient? If it is a T1 disease and the Gleason score is 6, 2 by 12, and the PSA density is more than 0.15 nanogram per ml. So we all know that it is not very low risk, but it is a low risk prostate cancer. And these two cancers we are going to discuss today, but the very low risk and low risk prostate cancer. So the low risk prostate cancer is grade group 1, PSA less than 10, and the disease is limited to less than 50% of one lobe of prostate cancer. And for it to be the very low risk prostate cancer, it must have all of these three characteristics plus less than 3 cores should be positive of the biopsy cores, and the PSA density should be less than 0.15 nanogram per ml per gram. So I think that we are clear about the very low risk and low risk prostate cancer. Coming to the management of very low risk and low risk prostate cancer, the only difference is that in the very low risk prostate cancer, if the life expectancy is between 10 to 20 years, the only option the NCCN gives us is the active surveillance, which is not the case with the low risk prostate cancer. The low risk prostate cancer, if the life expectancy is less than 10 years, it is observation. And if it is greater than or equal to 10 years, you have to go with some active plan. There may be active surveillance, EBRT, or radical prostatectomy. So it is the only difference between the very low risk and low risk prostate cancer. Why is there observation? Observation is there when the prostate cancer, when the life expectancy is less than 10 years. The answer is that the very low risk prostate cancer and low risk prostate cancer slows very slowly, grows very slowly. So it takes about 10 to 20 years to become symptomatic and to affect the patient in terms of morbidity and mortality. So we can go with the observation, and when the symptoms appear, we can treat the patient. Now, as we see here that when we go for the management, the first thing is the life expectancy. And how we define the life expectancy of a patient, it is a difficult thing. It is the main thing which makes the decision of treatment. So estimation of life expectancy for a group of people is easy, but when we are going to estimate the life expectancy of an individual patient in our clinic, it is going to be challenging. So these life expectancy charts come from WHO, from the Social Security Administrative tables, from the insurance companies, and they give us the life expectancy tables. And for a clinician sitting in his clinic, he has to see the health of the patient as well. If he is in his best quartiles of health, in the worst quartiles of his health, or in middle, so he has to add 50% or subtract the 50% from what the life expectancy has been given in the charts. So according to WHO charts, the life expectancy at birth in Pakistan for a male patient is 68 years. So when a patient comes to us and he is diagnosed with prostate cancer at 60 years, the life expectancy is less than 10 years. So it goes to the observation. So I would like to ask from Dr. Mekan how we are actually estimating the life expectancy of our population. What we do to see the life expectancy.
Thank you. Thank you. Can you hear me?
Yes, sir. Yes, sir.
Life expectancy, if we define life expectancy, and that is given in WHO charts, that is for present population that is just taking their first year of life, and they are expected to survive 67 or 68 year of life. But if the old age that is facing now, the situation of urinary symptoms are raised PSA or is diagnosed in low or very low risk, so it becomes very difficult question for us. In our setup, or what I am doing is I look at the comorbidities of the patient, organ functions of the patient, and if organ functions are normal and there is no comorbidity, and patient is around 60 plus, then I can expect that patient will be able to live another 10 years of good life. And on the basis of that, we can decide about the treatment or active surveillance. And we usually see these population, this group of patient is very small in our clinics. What we do is, if expectancy is more than 10 years, we are treating those cases. We are not, rarely we put the cases on active surveillance. I don't remember any case on active surveillance in my practice.
Thank
Thank
you,
you,
sir.
sir.
Thank you.
Sir, Dr. Nadeem, what is your experience regarding active surveillance? Do the patient really opt for it? And what is the percentage of the patients in your clinic who actually want active surveillance?
This is a good question. Actually, active surveillance is taken as one of the equivalent active management. There are recent articles I read, and I have to go back to it, that they're saying that active surveillance before was saying does not affect the outcomes. However, the more recent reports are saying there is 2.5% decrease in overall survival for the patient who were on active surveillance. So, however, the an active surveillance does not mean no treatment. It's just it's a kind of thing for most patients. It delay the treatment, and in some patient it for never require a treatment because they can die of other causes. So in my practice, I don't see active surveillance which people adopt, because during active surveillance, when you do PSA and the PSA going up, they become nervous about it. So most of the people actually adopt for the treatment, and active surveillance is only, it lasts only for short period, except very determined patients. There are very few. Most of the other patients, they think they know that they have cancer, and when we do all the time we do PSA, and then PSA go even 0.1 up and they become nervous. So we did a study in Cross Cancer Canada where we did it's called bias study. We published some early result, and my experience was when we do the PSA regular and we were doing all the imaging technique possible. Those days were choline PET scan, and I found in my practice that when we do the first diagnosis of prostate cancer, if they are low risk or low tier intermediate risk, they both are qualified for active surveillance. We found in about 2.5 to 3 years, 80% of the patient progress their disease. So when you do active surveillance, it is for a period of time. And among those 20% who was not, who didn't have disease progression, one of them was because of we were doing trust guided biopsy. One of them ended up in the ICU and hardly survived. So he opted for the treatment instead of active surveillance. So very few people who actually stick to this protocol, but it is a good start for some patients. The patient who are very low risk, it is a good start. And we explain patient everything. But now, before I was explaining patient, you do active surveillance or you do active management. The results are similar. It's just that active surveillance patient may get few years before we do intervention. But I don't think that is, I would be able to say the same. But I did not read the article in detail. There was two articles actually. One from Dr. Harvey Kwan in Calgary in Tom Baker Cancer Center. He recently published. Some of us know him. So he's a fellowship director there. He was working with me in past in Cross Cancer. So he found that they have a waiting time for brachy. The patient who want brachy seed implant, they were waiting for longer period, like 6 months, sometime a year. So he assessed them and he found the one who got treatment earlier and the one who was got on the waiting time. And these are the low risk and low tier intermediate risk for brachytherapy monotherapy. He found the results were different. So I think the indications are coming that active surveillance may not be absolutely equal to intervention, but how early, like, early 3 months is early, 6 months is early, 1 year, 2 year, we don't know. So generally my practice is I explain patient all the options, including active surveillance, and we monitor them. Most of the patients change their mind during course of few months. But if I find a patient who's going towards progress, then I usually, offer them that if they want to go for intervention. So we do start with active surveillance, and then many times we do switch to active intervention. Thank you.
Thank you, sir. So the active surveillance is a bit clear to us. Active surveillance is done in patient up to low intermediate risk prostate cancer, in high intermediate risk or unfavorable intermediate risk and high risk prostate cancer. We are not going to do the active surveillance. The other thing is that it is done when the life expectancy is more than 10 years. And how we do it is, no. The first question is that in the low risk prostate cancer, we have to see the PSA density, the number of cores, and the genomic risk. If the patient is BRCA2 positive, or more than 3 cores are positive, or the PSA density is high, we are not going to opt for the active surveillance. And the intermediate risk patient, we have to see the Gleason pattern. If the primary Gleason pattern is 4, we are not going to opt for the active surveillance. We have to give the treatment. How the active surveillance is done, the PSA is done every 6 months, the DRE, the repeat biopsy and multiparametric MRI are done yearly. When we see a change in the risk stratification, for example, the patient going from low risk to high risk or intermediate risk, then we have to intervene and we have to treat. The difference of active surveillance from observation is that in the active surveillance, we do the test regularly, and once we decide to treat, we treat with curative intent. But in case of observation, the intent to treat is palliative. The advantages and disadvantages of the active surveillance is that in the active surveillance, the only advantage is that we are deferring the side effect of the treatment. And the limitations of that, as Nadeem have told, that 50% of the patient will have to undergo the treatment. So they are going through a period of anxiety and followed by the same treatment. And the other limitation is that although the risk is low, it is less than 0.5%, this patient may present with a progressive or even metastatic disease. So these two are the cons of the active surveillance. As I have told you earlier, if the life expectancy is less than 10 years, or if it is less than 5 years in high risk patient, we put the patient on observation. That is, we do a history and physical examination yearly, and we don't advise any test. And once the patient becomes symptomatic, we start a palliative treatment. So the observation is recommended for asymptomatic patient. It is preferred for asymptomatic patient and considered in asymptomatic patient, but in the low risk, intermediate risk, and high risk, the life expectancy should be less than 10 years, less than 5 years for the high risk patients. We put the patient on observation. Again, the advantages and the cons of observation are the same. The advantages are that the patient avoids the unnecessary side effect of the treatment, and the limitations are that the disease may progress and the symptoms may come unexplained. मतलब हम पहले इन symptoms को pick नहीं कर पाते हैं और एकदम से symptoms आ जाते हैं patient को, that becomes worrisome for the patient. अच्छा. Apart from the active surveillance, the other option we have is the radical prostatectomy. For radical prostatectomy, there are 3 criteria. The one thing is that the disease should be limited to the prostate. The other thing is life expectancy should be more than 10 years. And the third one is that the patient must not have comorbids, because comorbids अगर हो गए तो फिर surgical intervention possible नहीं होता. और जो रेडिकल प्रोस्टेटेक्टमी के जो साइड इफेक्ट है, इनमें ब्लड लॉस हो गया, और इसके अलावा हम साइड इफेक्ट बाद में देखेंगे, जो सेक्सुअल डिसफंक्शन है वो रेडिकल प्रोस्टेटेक्टमी के साथ काफी ज्यादा है। So the urinary incontinence or जो erectile dysfunctions है, these are the most common side effect of the radical prostatectomy. Urinary incontinence 1 to 40% of the patients में urinary incontinence होता है, और in 1% of the patient that urinary incontinence is uncontrollable. बाकी जो 40% of the patient है उसमें इसकी severity इतनी ज्यादा नहीं होती है। When we talk about the sexual dysfunctions in case of prostate cancer, they are there both with the radiotherapy and radical prostatectomy, but they are more with the radical prostatectomy. With radical prostatectomy, the erectile dysfunctions are the most common. Sexual dysfunctions के अंदर तीन चीजें आ जाती हैं, erectile dysfunction आ जाता है, decreased libido आ जाता है, और dry ejaculations आ जाते हैं. But the most worrisome symptom for the patient are the erectile dysfunctions. So before going for radical prostatectomy, we must have a baseline scoring of the sexual health of the patient, और इसका एक चार्ट होता है, एक स्कोर होता है, वो हमें डिफाइन करना पड़ेगा कि उसके सेक्सुअल डिस्फंक्शन कितना ज्यादा है, देन वी हैव टू गो फॉर द प्रोस्टेटेक्टमी. अच्छा, इसमें नर्व स्पेयरिंग सर्जरी का जिक्र आता है लिटरेचर के अंदर. इवन इफ यू डू अ यूनिलेटरल नर्व स्पेयरिंग सर्जरी, there are 50% chances of sexual dysfunction, and if you do a bilateral nerve sparing surgery, there are 75% chances of sexual dysfunction. And this sexual dysfunction starts from day one, and it starts improving at 6 months, which is opposite to the radiotherapy. Radiotherapy में शुरू में sexual dysfunction नहीं आते हैं, they reaches at 6 months पे peak पे पहुंच जाते हैं, उसके बाद फिर कम होने शुरू हो जाते हैं. तो whenever you are going your patient for radical prostatectomy, you have to explain the urinary incontinence and the sexual dysfunction. The pelvic lymph node dissection, it is again a very controversial topic, but it is not indicated in very low risk and low risk prostate cancer patient. और हाई रिस्क में और इंटरमीडिएट रिस्क में इसके बारे में डेटा है कि हम पेल्विक लिम्फ नोड डाइसेक्शन करवा लेते हैं. अच्छा, the post op adverse features which are also indications
Dr.
of.
Nadeem,
Yes, madam.
I would like to ask Dr. Nadeem, sir, what is your experience of radical prostatectomy patients? How often do the patients opt for the surgical procedure, and what are the, like we see in literature, what are the actual side effects which the patients have?
Yeah, thank you. It's a good question. So as we're talking about that there is improvement in the diagnosis. There's also improvement in radiotherapy, direction, IMRT, SBRT. So there is improvement in the surgical techniques and skill as well. So we have multiple options now from surgery, like we were doing laparoscopic, open, and now we're doing robotic surgery as well. So with the robotic surgery, the hospital stay gone down, and the side effects should be lower, than the like open prostatectomy. So the hospital stay is lower, and people actually recover incontinence better. The issue with the nerve sparing is an option. It's a good option. But nerve sparing, they have to leave some normal prostate tissue around it. And for that reason, the PSA will go up after surgery. And when the PSA go up after surgery, then we don't know whether it is coming from the cancer or from the normal gland. And in those cases, like sexual dysfunction rate is lower with nerve sparing. But at the same time, we have risk for patient to require the salvage radiation treatment afterward because the PSA may go 0.2 or above. So we are radiation oncologists, all of us. There's no urologist probably here. So we can easily say whatever we want to. So at the moment, but as a standard, the treatment options include radiation, like, active surveillance for low risk and low to intermediate risk, active surveillance, radical external beam radiation treatment. There are different techniques, in that one, whether ultra hypofractionation, moderate hypofractionation, standard treatment, or brachy seed implant, so there are multiple options there in radiation. At the same time, surgery is an option as well. And then the techniques different, outcomes different. However, when I explain to patient about about the surgery, I do say to them that there is a risk, 30% risk that you may require the radiation treatment later on, and you may have the side effects of both treatment, not only one, but the results or outcome of surgery with 30% patient external beam salvage radiation versus radiation alone is the similar result. So I noticed in Oman last 2 years, there's none of my patient have gone for surgery, and I'm very unbiased to explain that because a urologist is there when I'm there. We explain unbiasedly our patient, and then the patient choose for the radiation treatment, especially when we have brachyseed implant. So many of them they want to opt for brachyseed implant. But the on standard, I would say that the all options are there because there's no head-to-head comparison, so we cannot claim one is better than other. Yes, of course, the side effects are different, and based on the side effect, patient can decide, which side effect he is willing to accept. So I am biased towards radiation. I would say the surgery may not required for most patient unless patient have a lots of urinary symptoms and they are very large gland that they may suffer the urinary obstructive symptoms later on. Those patients can be treated with surgery, but they are also not an easy case for surgery. Also, I find something that if apical region disease is present, then the risk of positive margin in apex is higher with surgery, and those patients are more higher risk of requiring the salvage radiation treatment later on, or pre-treatment PSA if it is high. For example, treatment PSA is 15 or just under 15. They are low tier, but at the same time, they are higher risk to require the salvage treatment later on because post-treatment PSA in those patients are slightly higher. So with all those factors, we can predict. Also, I just want to just a little bit talk about the PSA density and velocity and other PSA details. Actually, those are more relevant to diagnose the patient. Once you diagnose the patient, after that, I would say that we take all of them similar. And once that means for the better patient for biopsy or not, I depend on more on density or velocity. But after biopsy, when it's diagnosed, their role of deciding what management is minimal, as not as much as before biopsy. So those factors we can consider. Now the treatment option, when we should explain unbiasedly that all options are there, but they have different side effects. So I don't have any challenge to get the patients for me so far by this approach. So I would say that all options are good.
Dr. Nadeem, I have a question. You are rightly biased for
Yes.
radiotherapy for early and low risk disease.
Yes, I do.
You're rightly biased.
I'm radiation.
And there are different
Yeah.
there are different techniques: brachytherapy and external beam radiotherapy with moderately hypofractionation or ultra hypofractionation. What is your choice on the basis of results and side effects?
Okay. So very good question. Like if someone is eligible for all option, I prefer for brachyseed implant as monotherapy for low risk and low tier intermediate risk. Some patient may not be eligible or service is not available. In those cases, at the moment, the ultra hypofractionation is not considered fully standard at the moment because the long-term results are not there or treatment outcome results are not there, but toxicity profile have shown that this is doable. And from some retrospective and some other prospective data, non-randomized, showing that they are equivalent in the outcome. So I prefer brachyseed implant if not available service or patient not eligible. I go moderate hypofractionation, something like the study from UK where we give 16-20, or if patient is from a distance, like patient tell me that there's a difficulty in coming to the treatment, or they say that the cost is an issue for number of fractions, then in those cases, I do take ultra hypofractionation, which has two options that either we give alternate day treatment or we can do once a week treatment. So there are a couple of studies. So most people know about PACE-B trial, which we published for 2-year data and found the toxicity rate is very tolerable and good so far. They were giving 36.25 in 5 fraction alternate days by using tight margin of 5 millimeter around 3 millimeter posterior without fiducial marker. So some of them patients were on the fiducial marker, some were not. So it's okay. I do without fiducial marker, and I give 40 gray to prostate and 30 36.25 to PTV. And I offer patient option either alternate day or once a week. That is a Canadian trial. I forgot the name of the trial where they compare both options and they find a similar outcome for both either once a week treatment or alternate days, but toxicity was lower in once a week treatment. So I do offer non-standardly our patient ultra hypofractionation when the situation help him. Otherwise, I try to stick to the moderate hypofractionation. And standard we are not using nowadays.
What about the toxicity of radioactive seed implants or moderate hypofractionation radiotherapy?
Yes, so they are actually comparable, a little bit different. That moderate hypofractionation may have risk of rectal proctitis more, or brachytherapy may have more urinary symptoms. But to be honest, I've over years and years, I haven't seen proctitis after using this IMRT, IGRT on daily cone beam CT. I haven't seen any patient having up to rectal bleeding. There may be proctitis which we may not diagnose because we're not doing a scope, but not much. And toxicity very comparable. So, but the only difference I can explain patient that in brachy it is more urinary symptom, and in external beam radiation more rectal problems. But honestly, they are so tolerable and so little that it's to me is negligible. But I found the brachy when I do, because the dose is naturally higher brachy, because some of the areas get actually up to 200 300% of the dose. Average dose for brachy seed implant I did in Oman for 10 patients is about 220 230 gray. So average dose is high, but the toxicity doesn't go proportionally high, and their PSA drop very quickly to nadir level, like under 0.5 within like 6 months time, then external beam radiation. So I do prefer brachyseed implant if it is available, but I know it would not be available everywhere, and I'm not saying that not doing it is a disadvantage. If it is there, can be an advantage, but not there, it is not disadvantage. The only patient which I will feel brachy should be must is salvage brachy. When patient fail after external beam radiation, focally only in prostate and no metastasis, then brachy is the best available treatment for them for salvage option.
And how commonly do you see
Thank you, Dr.
dry
Farooq.
ejaculation or painful ejaculation? Do you see in your patients?
I think the patients in our and they don't complain about this usually. In our, the men in our region, if you're going with a nurse in the clinic, they usually don't complain. When I ask them, sometimes they do about dry ejaculation or painful ejaculation. They do some
All right.
complain. If they complain about mostly you,
Mm-hmm.
What I do, Dr. Faru, that in the beginning, before do the treatment, I do explain patient these are possibilities. So they probably this may be the reason that they do accept it as part of the treatment, and they do understand this is a side effect of treatment, so they don't complain about them. But I'm sure
Okay.
they may have it, but they're not complaining about it. Yes.
That's good.
So my
Thank
question to Dr.
thank you.
Guptan. Sir,
Ji.
how often in your clinic patients they are like conscious of the sexual side effects, sexual dysfunction when of prostate cancer patients? How often they do discuss these things with you?
Rarely. Discussion regarding sexual function or sexual health of the patient, that is a social taboo here. Dr. Nadeem might know about it, and nobody talks about it. I have never heard any complaint regarding sexual activity and sexual evaluation. Usually, we are not doing it as well. Maybe we should start it, but presently, we are not assessing the sexual health of the patient. And if I ask, usually patients start smiling at me and laughing at me, and then I have to quit my question.
Thank you, sir. Sir, have you seen any patient of undergoing radical prostatectomy in your clinic?
The straightaway answer is no. Radical prostatectomy, usually urologists are not doing here. I have not seen any case with radical prostatectomy, and I'm having problem when I am giving local radiotherapy and there is PSA failure, biochemical failure of the disease, and PSA is rising, and I'm sending the patient to urologist, but there's service is not provided to those cases here in Lahore at least.
Dr. Nadeem, what is your experience with salvage surgery?
Take this big step because they're a bit scared about the complications. So when I was in Canada, I noticed that one of the surgeon in British Columbia for 3 or 4 provinces, he was dare enough to go for radical surgery. So, but in the Middle East region, I didn't see the surgeons want to do that, even though they keep repeating to us that surgical salvage is an option. And when I asked them, patient, can you do surgical salvage? They always say no because of this issue or that issue. So they shy away from it. I don't think they have this experience of doing the salvage surgery. So now with the results of RTOG 0526 study where LDR seed implants have very good results, like it's about 5-year outcome up to 70%, which is very good for salvage situation. And toxicity rate is comparable or tolerable. In those cases, I think I would take that LDR seed implant as a standard. There are other options people are exploring, like focal therapy of in positive area with HDR. Again, but we don't have the much of the data for that. So I would say that I haven't seen any patient surgical salvage yet, but I have done myself many for with the brachy seed implant.
Thank you, sir.
Salvage with brachy is becoming a very good option, and unfortunately, we don't have this facility in Pakistan. I was trying to bring the facility regarding HDR, and that is in process. But one of my case that I had to do external beam radiotherapy after maybe I think 5 years, and the salvage re-radiation with external beam, that patient tolerated well, and that patient is on follow-up. Again, the PSA is rising, and I am not getting support from the urologist in that case. Thank you.
Thank you, sir. Dr. Main, please discuss the next topic.
Thank you, sir. Thank you. Then the next topic has been made very easy.
Also, just one thing is that we sorry, just one point that so if you see a salvage case, I feel like this is a service to our patient and very important option. We don't mind accepting the patient from abroad from different countries, and I'm working currently on the pricing to bring it as low as possible that everybody can cope with it. So anyway, that if you have any salvage case, then can contact me and we'll see if we can do something.
Thank you. Thank you.
These are the indications of post-operative radiotherapy, the positive surgical margins, T3 disease, and detectable PSA after once it's undetectable. So as Sir Nadeem said that 30% of the patient are upstaged after the radical prostatectomy, so they might have to undergo both of the procedures, surgery as well as radiotherapy. So there is oncotype DX testing for prostate cancer now, that which patients must undergo radiotherapy and hormonal therapy after radical prostatectomy. We will discuss it later on. The topic of radiotherapy has been made very easy after the discussion of Dr. Nadeem and Dr. Mekand. I will just highlight some of the important points that radiotherapy in case of prostate should be done with highly conformal techniques. The second important thing is that dose escalation has a role in radiotherapy, especially in case of biochemical free failure survival. And the third thing is the hypofractionation. So these 3 terms we will understand today. For the first thing is that for low risk prostate cancer, we are not radiating the nodes, and we only irradiate the prostate, not the seminal vesicles. And these are the different protocols of radiation therapy we are using. The moderate hypofractionation, the conventional fractionation, which is up to 74 gray, the SBRT or the ultra hypofractionation, which are in 5 fractions. So we see here that for the very low risk prostate cancer and favorable intermediate risk prostate cancer, all these 6 options are there. The high dose rate brachytherapy, the low dose rate brachytherapy, and the 3 fractionation schemes are applicable for our very low risk and favorable intermediate risk prostate cancer patients. Once we go to the unfavorable and high risk prostate cancer, then the high dose rate and low dose rate brachytherapy alone is not indicated. We have to give AVRT, and the high dose rate a boost can be given. So this is the difference in terms of
My
treatment.
question to Dr. Nadeem is, sir, how do you like to plan a patient or whether to go for HDR or LDR? Like, what are the difference between them?
For HDR at the moment, this monotherapy, if you means for brachy you're asking about, or
For
ultra hypofractionation and moderate hypofractionation? For
brachytherapy,
brachy.
if you are
So
opting for
brachy is, yes, yeah. So monotherapy, only established data for long term is LDR monobrachytherapy. There is no HDR established data. However, in UK and some other setup, people are doing, they did first one single fraction of 19 gray. First case was done by my resident, Dr. Nasir Al-Debani. He was on Fox News for this, doing that from William Bowman Center. So they did single to compare with LDR monotherapy. So there is one single fraction, and the results, long-term results, were poor. So that discontinued. Now the Sunnybrook from Dr. Jerry Morton and some other centers, some centers in UK, they're doing 2 fractions, 13.5 or I think 12.5, 2 fractions, 1 or 2 week apart, LDR, HDR. And the results, long-term results are not there, but I just saw one retrospective data, which is not equivalent to monotherapy, however, closer to monotherapy. So if you ask me, I would, if the facility allow me, I will do LDR brachytherapy as monotherapy. HDR, I keep it for reserve for the boost. If we do external beam, plus we give the boost, we need to give boost. So LDR brachytherapy was used it for SNRT trial. They showed better outcome, and all high-risk patients actually deserve that. For high risk means localized high risk patient. They deserve that, to do the boost by brachy after external beam. And LDR was the method used. But my own feeling is there is no randomized trial comparing, but HDR easier. And now the HDR boost is only one single fraction. So I have a plan to actually, in the boost setup, to do a randomized trial where we do LDR compared with the HDR in the boost setup. As primary treatment, I have no doubt about, I have preference for LDR monotherapy. If there's center they don't have, then and patient wanted to have brachy, then we can do in 2 sessions HDR brachytherapy to hold prostate.
Thank you, sir.
Thank you. So I have put this image of 2D just to tell that in the prostate cancer, dose escalation has a role. So the benefit of the patient gets benefit when he receives 74 to 78 gram dose, and if we are doing 2D therapy, then we cannot actually measure the dose to the rectum and bladder, and the patient will have these side effects. And if we give up to 70 gram dose, this dose is not enough. So putting this slide here, the purpose is that if in your center you don't have the facility of IMRT or VMAT, you have to refer the patient of prostate cancer to a center where a 3D CRT or IMRT or VMAT is done, because dose escalation, without dose escalation, you will underdose the prostate cancer, or if you are doing with full dose, then the patient will have proctitis or cystitis. In case of 3D CRT or IMRT or VMAT, the CT simulation is done with 2 centimeter above the iliac crest to the mid femur, and then the GTV is not there when we are doing CT based imaging, but if MRI based, we can draw a GTV. The CTV is entire prostate plus minus the spinal vesicles plus minus the lymph nodes. In case of low risk prostate cancer, we are not taking the spinal vesicles nor the lymph nodes. And the PTV margin depends upon the setup. If we are doing moderate hypofractionation or if we are doing ultra hypofractionation, it will depend on that. So this slide is showing the benefit of dose escalation in all the trials from MDEC to GETAC 2011. In all the trials, dose escalation has a role, especially in biochemical ferial-free survival. So this slide also is showing that even if the more in cases where PSA is more than 10 nanogram per ml, they are comparing 70 gray with 78 gray, and we see here the ferial-free survival and the separation of the curves months after the radiotherapy. So the dose escalation has a role. And this slide is showing that dose escalation has a role in the PSA, in the local recurrence, in the nodal recurrence, in the distant mets, and in the biochemical failure-free survival. They are comparing the 70 gray with the 78 gray, and that is lower with the 78 gray fractionation. In this slide, as I have told you earlier, that with the RT, we have to keep in mind these two things, the hypofractionation and the dose escalation. The dose escalation, as I have already explained, for the hypofractionation, we have the moderate hypofractionation and the ultra hypofractionation. The CHIP trial was actually the main trial which compared the 74 gray in 37 fraction with 60 gray 20 fraction, and they have established that this 60 grade 20 fraction is non-inferior to 74 grain 37 fraction with acceptable tolerance. And they also proved that in the 60 gray arm, the biochemical free survival, 5-year biochemical free survival was 90.5%, and in 74 gray arm, it was 88%. It is almost equal. So this trial has proven that hypofractionation is non-inferior to the standard fractionation. I have put the dose constant.
Dr. Meen?
Yes, madam.
I would like to ask Dr. Nadeem, sir, please tell us about the bladder and bowel preparation while you are doing CT simulation and also do the treatment of the patients.
So it's a very important and very good question, because now the most important thing I found in the prostate cancer treatments is rectal preparation. Bladder preparation, I am doubtful, because when we are treating, we are now talking about low risk and low to intermediate risk. In this case, we only treat prostate. We don't even treat seminal vesicle. And if you look into when we draw the prostate volume, about a couple of slices, we do include seminal vesicle automatically in the prostate volume, because they're so attached that you cannot see them separate. So anyway, for these cases, bladder preparation was mainly used for four-field box technique in the past, when we try to avoid the bowels from the four-field radiation area by filling the bladder. Now that is a lot change. Now I am just thinking about and going to start a study later on, is about bladder prep or no prep, any impact in the prostate cancer. However, rectal prep is very, very important for the prostate cases. So what I do, I usually advise our patient that for 3 days, no low residual diet, with the milk of magnesia, 30 mils BID morning and evening, 3 days before CT simulation and 3 days before starting treatment, and continue during treatment. But if they have loose motion more than 3 times, then we do ask them to either cut down milk of magnesia or stop it. So the rectal prep is very important, and I know that people use 4 centimeter criteria for rectum size, but that's not only just the empty rectum is the one what we want. And during the treatment, I do cone beam CT daily, because my margin posteriorly is tighter. So the study we did, the CHIRP study in high risk prostate cancer, which is now new standard 68 grain 25 fraction. So we use 3 millimeter posterior margin, and we use 5 millimeter around. However, in Middle East or some other country, I'm still practicing 7 millimeter around and 5 millimeter posterior, but I do trim off any PTV on rectum, not more than 3 millimeters. So I do modify the PTV myself if the rectum is more than 3 millimeter, which can be, which was apical region where the come from the pear-shaped gland from top to bottom. It may be, some may wear sometime even 1 centimeter. So we need to cut that on those. And so the rectal prep is the most important factor. I stress on that and I continue. And it make in my opinion, the therapists work with me or physicist or radiation oncologists, we observe that during the treatment, and they all agree that this make an important impact on patient. But bladder prep, if they are comfortably full, like 500 mils, so they can pass urine first and then drink 500 mils of water, and then just after within like 20 minutes or so, you can do CT sim. We don't want them to be too full; that will make them uncomfortable and they may move. So reasonable bladder prep and very good rectal prep is important.
Thank you so much, sir. Thank you.
So the rectal TD55 is 60, and for bladder it is 66 gray. But once we are doing the confirmer radiotherapy, then even we can give 80 gray to 15% of the bladder and 75 gray to 15% of the rectum. All this depends on the type of fractionation we are using. So about the brachytherapy, the interstitial implantation of prostate plus minus seminal vesicles with temporarily high dose rate HDR or permanent low dose rate radioactive sources for monotherapy as a boost when added to AVRT should be performed in practices with adequate training, experience, and quality assurance measures. So one of the difference of the brachytherapy for external beam radiotherapy is that in the brachytherapy, the patient experience some acute side effect, acute urinary side effect, which are pain and urinary obstruction. So any patient who have a urinary obstruction or pain or the prostate volume is less than 50 ml, he is not a candidate for brachytherapy. So the IPSS is the International Prostate Symptom Score. It should be less than 10. No priority URP, grand size should be less than 50 ml. These are the requirements for the brachytherapy to be given. Other than that, the longer side effect of brachytherapy and external beam radiotherapy are similar. And for brachytherapy, we use iodine 125 and the palladium 103 with the energies and half-lives given here. The dose of monotherapy for iodine is 145 gray, and the dose of PD103 is up to 125 gray if we are using it as monotherapy. But when we give as boost dose, it is up to 100 gray.
I would like to ask Sir Nadeem, sir, which source you actually use while doing LDR? Which is the more practical one, iodine or the palladium?
So my all experiences with iodine 125 for the prostate cancer. However, palladium can be used because it's a faster dose delivery. But what I use the breast cancer seed implant, then I use palladium because of the the radiation exposure. So that's because the half-life shorter do help. For the prostate is mostly iodine 125, but it can be palladium as well. Now, just one quick thing is for urinary symptoms that we use IPSS score, or we use urodynamics study, and these are they are just a guidance for us. I found they are non-relevant to urinary toxicity after treatment, so it's really difficult to know which patient will have more urinary symptoms. But we do still, I was doing IPSS score in Canada, and in Ireland I was using this urodynamics study, but they were like non-relevant somehow, or maybe patient genetic composition or whatever reason, even not the dose of radiation to urethra. So I don't know what factors makes urinary toxicity, can we predict with them overall, because the toxicity is if it happen, if it may not never happen, but if it happen, then it's a lower percentage. So I wasn't using either urodynamics. I personally, some other physician do, I wasn't using much for them. But in case if someone have very high IPSS, okay, of course, then I just think about they may have they may be more of problematic later, and then we rediscuss the treatment options.
Yes, sir.
So up till now, we have discussed the three main options in case of low-risk prostate cancer, which are the active surveillance surgery and radiotherapy. And there is a trial which is called PROTECT trial. This trial is actually comparing the three arms, which one is better. So in April 2023, they have presented the 15 years outcome after monitoring surgery and radiotherapy for prostate cancer. So we see the results of this trial. The background was that all these patients were diagnosed with PSA testing, And after that, they were put in 3 arms, either active surveillance or radiotherapy or surgery. And they concluded that after 15 years of follow-up, prostate cancer specific mortality was low regardless of the treatment assigned. So after 10 years, the mortality rate is 1%. Only 1% of the patient will die of prostate cancer in 10 years. Thus, the choice of therapy involves weighting the pros and cons of the 3 options we have. So they interpreted that the RT plus ADT and radical prostatectomy shows no difference in prostate cancer mortality or distant mets. Active surveillance had worse distant mets and ADT salvage, but this does not lead to worse prostate cancer mortality at 15 years. So the mortality is same in 3 arms, in all 3 arms. The RT had slightly worse long-term loose stools, blood in stools, and GI incontinence compared to active surveillance. Late nocturia is similar between RT and active surveillance. 12-year toxicity results were similar. So this leads us to the conclusion that once a patient with low risk or very low risk prostate cancer lands to our clinic, the decision between the active surveillance or the radical prostatectomy and the radiotherapy depends upon the toxicity profile. And with the radical prostatectomy, the sexual dysfunction is the main concern. 22% of the patient have urinary incontinence. No, sexual dysfunction is present in 22% of the patient. Urinary incontinence is there in 1 to 40% of the patient. Erectile dysfunction is 50% with bilateral nerve sparing surgery and 75% if unilateral nerve sparing surgery. It improves with time if nerve sparing is done. And with the radiotherapy, the most important side effect is the gut toxicity. As Sir Nadeem have told that with the IMRT and VMAT and the daily image guided radiotherapy and the judicial markers, the gut toxicity also has decreased. And but this is one of the chronic symptoms, and patients do come with proctitis, but not with blood in the stools. The urinary irritative or obstructive symptoms. This is different from the radical prostatectomy where the patient comes with incontinence, but in radiotherapy, the symptoms are obstructive. There are erectile dysfunctions in 12% of the patient, but all these symptoms peaks at 6 months, then gradually decreases except the bowel toxicity. So this prostate quality assurance trial and the protect quality of life trials have shown the results that the decision about the treatment is based on the toxicity profile. The biochemical relapse or failure is defined as 3 consecutive rise in the PSA values from the nadir value if the patient has received the EBRT. EBRT के बाद जो PSA वैल्यू हम करवाते हैं वो वंस नेडिर पे आने के बाद अगर दोबारा राइज कर जाता है और वो 3 कंजेक्टिव वैल्यू में राइज कर जाता है तो इसको हम बायोकेमिकल रिलैप्स या फेलियर कहेंगे. और फोनिक्स डेफिनेशन में ये कहा था कि राइज ऑफ 2 नैनोग्राम पर एमएल ऑलमोस्ट अबव द एब्सोल्यूट PSA नेडिर. अगर ये एक दफा भी आ जाए 2 नैनोग्राम पर एमएल, so it will be declared as biochemical relapse or failure. If there is a detectable PSA after radical prostatectomy, it is called PSA persistence. And if it becomes detectable in 2 occasions or its value is more than 0.1 nanogram per ml at any occasion after once reaching the undetectable value, it is called PSA recurrence. So remember that the recurrence and the biochemical failure is different for EBRT and for radical prostatectomy. It is very understandable that once radical prostatectomy is done, after 5 to 6 half-lives of PSA, the PSA value in blood should be undetectable. If it becomes detectable and it is greater than 0.1 nanogram per ml at any occasion, it is called biochemical failure. In case of EBRT, the value is up to 2 nanogram per ml because the prostate is there and it produces some PSA. So the criteria is different. How we follow the patient is that the first follow-up is at 4 to 6 weeks after radiotherapy. Then in the first year, it is after every 3 to 4 months. In the first 5 years, it is 6 monthly, and then it is annually. And we do it with the history and physical examination of PSA every 6 months to 1 year. and an imaging study if it is indicated by the clinical examination or a rise in PSA. So thank you so much. If there's any question, you can ask. Thank you so much.
Thank you so much, Sir Mekan and Sir Nadeem, for taking your time. I hope this session was very helpful for all our trainees, for all the attendees. And if there are any questions, you can ask now, or you can just send messages, and we will share the answers.
Thank you very much. It was a very good session and a good participation of the attendees. And it was good to be part of the session with Dr. Nadeem. I learned a lot from Dr. Amin and Dr. Nadeem. Thank you very much.
Special thanks from me as well. It's very good to exchange knowledge and to learn from all these topics. There are things which I don't know before this this talk. So thank you very much for this, and thank you, Dr. Farooq, to be here.
A very special thank you from Jivon's side, all our guests from Enmol, and Dr. Nadeem for joining us today and enlightening us on all of these aspects of the management of low-risk prostate cancer. A very special thanks.
Thank you, everyone. Allah Hafiz.
Bye. Allah Hafiz.
Okay, ji, Allah Hafiz. We don't have any questions. We can conclude the session. Thank you, everyone, for joining.